Let me know when to start. I think I can start, right? So, very good evening to all INI SS Surgical Gastro aspirants. So, today I'll be covering a recall session of last May exams, particularly on hepatobiliary portion. So, let's move on to the questions. It included almost 20 to 25 questions, and most of them are taken from Shackelford, few of them from some other sources also. So, first question, which I'm going to discuss, is a liver tunnel procedure, which is not removed. So, a liver tunnel procedure, segment 1, segment 4B, segment 8, and middle hepatic vein. And the answer is segment 4B. See, liver tunnel is a procedure. I'll just run the short video, which will give you an clear-cut idea. So, these are particularly for tumors which are close to the hepatocaval junction involving the middle hepatic vein. But if there are communicating veins between the distal most portion of middle hepatic vein, between that and right hepatic vein, between that and left hepatic vein, we can resect the segment 8, segment 4A, segment 1, along with the middle hepatic vein, provided the proximal things are drained, like segment 4B and segment 5 are drained through alternative communicating veins. I'll run again. So there's a tumor in segment 8-4B, communicating veins between the distal portion of middle hepatic vein and right hepatic and left hepatic vein. So segment 4A, segment 8, segment 1, and the proximal most portion of the middle hepatic vein is resected. So that the segments 4B and 5 are drained through the communicating veins between middle hepatic vein, left hepatic, and right hepatic vein. So these are called as parenchymal sparing hepatectomies started by Torzilli. So the mini meso hepatectomy, which is a slight modification of liver tunnel procedure, involves removal of segment 4A, 8, and middle hepatic vein. But if it is including segment 1, then it becomes a liver tunnel. So if we see from below, above IVC, nothing will be there going from the infrahepatic portion to suprahepatic portion. There will be a tunnel-like thing. The superior wall of tunnel will be formed by segment 4B and 5. So next question is Strasberg. Sorry for the spelling. Did all procedures except? So he introduced critical view of safety. He classified subtotal cholecystectomies. He described R4U line, and he also described ramps for distal pancreatosplenectomy. So the answer is he did not describe R4U line. So what is R4U line? This is again a line going fairly horizontal line, starting from the Ruvius sulcus, going in the base of segment 4, and then going to the junction of umbilical fissure and the horizontal portion of the left portal vein. So the concept is, if we stay above this R4U line, which is an imaginary line, the chances of injuring the vital structures are very, very less, as we can see in this picture. Now, the critical view of safety, subtotal cholecystectomy types like fenestrated and reconstituted types, RAMS, which is radical antegrade modular, pancreatosplenectomy, which is explained for adenocarcinomas of body and tail of pancreas, was all defined by Strasberg. So the next question is, which is not a component of SAGES guidelines, recent guidelines for laparoscopic splenectomy. So they have come out with recent guidelines and their corresponding evidences. So which among the following is not a recommendation? So right lateral position is better than supine, no drains for elective cases, hilum control with energy device than mechanical device, and intra-op platelet transfusion. So the answer is hilum control with energy device than mechanical is not a component of SAGES guidelines for laparoscopic or SAGES recommendations for laparoscopic splenectomy. They do recommend usage of either staplers if it is a case of magistral distribution, distributed distribution. If it is a magistral distribution, they are recommending clips. So these are the latest guidelines which came a year back. Should routine drain placement versus no drain placement, the panel suggests no drain for routine MIS. And the position, they have recommended right lateral position over supine position for normal side spleens. And they have preferred intraoperative platelet transfusion in case of ITP than preoperative platelet transfusions. So the next one is hilar cholangiocarcinoma. Which among the following is false? 60% of hilar cholangiocarcinoma are sclerosing types. Sclerosing types are easily resectable. Left-sided second-order biliary radical involvement with right portal vein involvement is unresectable, and 50% are resectable at presentation. So sclerosing type, though they are very common, they are not easily resectable. There are three types of hilar cholangiocarcinomas: sclerosing type, nodular infiltrative type, and papillary type. The papillary type is the one which spreads intraductal and they are easily resectable, whereas most common type is the sclerosing type, which come to close to 60 to 70%. They have periductal infiltration and they are not easily resectable. Now, there are different criteria for resectability of hilar cholangiocarcinoma, which will be coming to the next one. At presentation, 50% of hilar cholangiocarcinomas are resectable either upfront or after draining them with PTVD. Now, we all know that biliary malignancies other than carcinoma gallbladder, the response to neoadjuvant chemotherapy is not yet proven. So, surgery stands as the main modality of treatment. So, 50% of the patients with hilar cholangiocarcinoma at presentation will be resectable either upfront or after neoadjuvant chemotherapy. Now, the resectability criteria for hilar cholangiocarcinomas, it depends upon what side portal vein is involved and what side atrophy is there or what side second order biliary radicals are involved. Now, for example, hilum involving unilateral or, for example, right-sided second order biliary radical with right portal vein is involved, then they are resectable. Now, if right-sided portal vein is involved, there is left-sided atrophy and left-sided second-order biliary radical involvement, then it is not resectable. Main portal vein, as of now, is considered as unresectable, and bilateral second-order biliary radicals is still considered as unresectable. Same applies for this also. N2 nodal involvement, distal metastasis, lobar atrophy with contralateral portal vein, lobar atrophy with contralateral second-order biliary radical involvement, and all those things. Bilateral hepatic artery and portal venous involvement of unilateral hepatic artery and contralateral ductal spread. Similar to this, all these are criteria for unresectability of cholangiocarcinoma. So the picture for MRCP double duct sign had come. So that classically occurs in carcinoma pancreas. Carcinoma gallbladder, CCP and distal cholangio, they don't come. They may still come in cases with ampullary carcinomas where both bile duct and main pancreatic duct is dilated. They don't come in carcinoma pancreas. So this is a classical MRCP, which is T2 weighted heavy image of a patient with a suspected head of pancreas tumor. And there is a cutoff of a dilated CBD and dilated MPD. Regarding carcinoma gallbladder, one of the following is false. Staging, T1B involves muscle and it involves less than 5% with lymph node spread. In case of T1A, subserosal cholecystectomy is sufficient. Stage 3 post-radical chole 5-year survival could be as close to 40 to 50%, and minimum 6 nodes are required to stage carcinoma gallbladder properly. So T1B, there is no submucosa for carcinoma gallbladder, and T1B does involve lymph nodes in almost 18% of the patients. And that is why these days the recommendations are slightly changing for lymph node or completion radical cholecystectomy in patients who are presented with T1B. Earlier, 10, 15, 20 years back, T1B, there was a debate versus radical cholecystectomy or just follow-up. But since the evidences are building that 18% definitely have lymph nodal spread at that time, completion radical cholecystectomy, if it is an incidental gallbladder carcinoma, is recommended. Now, T1A, subserosal cholecystectomy or the regular simple cholecystectomy is sufficient. Stage 3, though the numbers seem to be quite high, Shackelford comes with this value that 5-year survival post-radical cholecystectomy. Obviously, I believe it would have included including post-operative or pre-operative chemotherapy. The 5-year survival, there it was between 40 to 60%. And the recent AJCC guidelines, 8th edition, recommends at least 6 nodes to be removed for appropriate staging of carcinoma gallbladder. So additional debate surrounds management of T1B. This again are exact words from chapter 19, 119 of Shackelford, with studies suggesting that T1B disease can be present with lymph node metastasis up to 20% of the patients, prompting most authors to advocate for radical resection. So intrahepatic cholangiocarcinoma, the least presentation. In other words, amongst the following symptoms, which is less likely to be a mode of presentation in a patient with intrahepatic cholangiocarcinoma. Number 1, jaundice. Number 2, weight loss. Number 3, right upper quadrant pain. Number 4 is incidental. So the answer here is jaundice. Unlike a distal cholangiocarcinoma or hilar cholangiocarcinoma, which are usually presented with jaundice, intrahepatic cholangiocarcinomas are routinely diagnosed most of the time incidentally, or incidentally, patient had right upper quadrant pain and weight loss, got an ultrasound scan done, and further evaluation ended up having an intrahepatic cholangiocarcinoma. Now, the same words from 9th edition Shackelford, although most patients with hilar and distal cholangiocarcinoma ultimately develop jaundice, in case of intrahepatic cholangiocarcinoma, who may even develop a segmental or incomplete lobar obstruction, hepatic atrophy also they can develop, but still they may not have frank jaundice. So this we can correlate with the fact that if a patient with hilar cholangiocarcinoma or distal cholangiocarcinoma or carcinoma head of pancreas with obstructive jaundice, only 30% of the liver needs to be drained so that the patient is off jaundice, which means even if 60 to 70% of the liver is atrophied, remaining 30%, there is no IHBRD, it is normal, then the patient may not develop jaundice at all. So jaundice is the least possible presentation of a patient having an intrahepatic cholangiocarcinoma. Moving on to the next question, the common hepatic duct complete injury 1 centimeter below the confluence, what is the next management? And the options given include Roux-en-Y hepaticojejunostomy, duct to duct over T-tube, duct to duct without stent, ligate, and placer drain. Now, all options seem to be very viable, but which one will be most appropriate? The answer is Roux-en-Y hepaticojejunostomy. And these are the words from chapter 20 of Shackelford 9th edition for small non-circumferential injuries. The question is complete injury. So non-circumferential injury, a primary repair with an absorbable suture can be performed over an externalized T-tube. So this is what the recommendation says. By contrast, complete biliary transection should be repaired as like similar to a delayed construction with end to side Roux-en-Y hepaticojejunostomy using interrupted absorbable sutures. So even in acute setting, if the bile duct injury is in the form of complete transection, then the reconstruction should be with Roux-en-Y hepaticojejunostomy with interrupted sutures. Now, in what conditions we can do a primary repair, what conditions we can do T-tube drainage and all those things? See, if it is less than 1/3 circumferential injury of common hepatic or common bile duct, it can be repaired over T-tube. Alternative is to repair over a placement of a intra-CBD stent. But if it is more than 1/3, whatever repair we are going through, they may end up having a stricture. So if that is the scenario, it's always better to do a reconstruction properly in the form of Roux-en-Y hepaticojejunostomy with interrupted sutures. It's a special scenario where a patient following cholecystectomy develops a bile duct stricture 6 months after gallbladder removal. So which among the following is true statement? Remember, it's not an immediate injury, it's a immediate presentation, it's a very delayed presentation. The options given include histopathology of the gallbladder specimen or is not useful. Delayed strictures are usually associated with traction injuries. MRCP alone is enough for surgical planning, and tumor markers will be diagnostic in these scenarios. I will repeat the option. Histopathology of the primary surgery of gallbladder specimen is not useful. Delayed stricture are usually caused by traction injuries, and MRCP alone is enough for surgical planning, and tumor markers will be diagnostic in this scenario. Obviously, the last option is false. Delayed strictures are usually mechanical, thermal, rather than mechanical injuries. It's either thermal, vascular, or traction injuries. Now, remember, late strictures are usually vascular, thermal, or malignancies. Malignancy should be a DD if the presentation is delayed. Okay. So more delay is the presentation, underlying suspicion for malignancy increases. For example, if the same patient had a biliary stricture, new onset biliary stricture following cholecystectomy 1 year later, 2 years later, then the suspicion of malignancy increases. Definitely, histopathology of cholecystectomy has to be reviewed with an expert pathologist. Tumor markers will be elevated in any kind of jaundice, and PET-CT increases the diagnostic value. Okay, so MRCP alone may not be sufficient. So identify the type of cold cyst in this picture. What we can see is there is a ERCP with specific cannulation, and there is a dilatation of um, common bile duct, common hepatic duct, cystic duct. Particularly, the left duct is dilated, right duct doesn't seem to be dilated. It is uniform, and there is a long common channel. We can see here there is a long common channel of both bile duct and the pancreatic duct. So the options given include type 4A, type 4B, type 1, and distal CBD calculus. Obviously, distal CBD calculus is not there here. In this case, it is type 1. Now, this is Todani classification where there is type 1, type 2, type 3, type 4, and type 5. Type 1 is further subclassified into A, B, and C depending upon the type of dilatation and the length of dilatation of the bile duct. Type 1A, the entire extrahepatic biliary radical is dilated, particularly common hepatic duct, common bile duct, and cystic duct. Type 1B, only a cystic dilatation of common bile duct, common hepatic duct is normal. Fusiform dilatation of the extrahepatic biliary radical with some reflection into a common right and common left hepatic duct, not to the individual second order biliary radicals, is type 1C. Type 2 is choledochal diverticulum kind. Type 3 is choledococele. Type 4A, dilatation of both intrahepatic and extrahepatic biliary radical. See clearly, there is a narrowing at the hilum. The dilatation of extrahepatic, intrahepatic is separated, unlike 1. Okay, type 4B, it is only extrahepatic radical dilatation, but multiple. And type 5 is only intrahepatic radical dilatation. Okay. So this terminology was there in the current Shackelford. Congenital biliary dilatations, which include type 1A, type 1C, and type 4A. They are associated with the abnormal pancreatobiliary duct junction, whereas type 1B, type 2, type 3 are usually associated with normal pancreatobiliary junctions. Okay. Type 4B, multiple areas of extrahepatic biliary radical dilatation. It doesn't involve intrahepatic biliary radicals. This also is not usually associated with abnormal pancreatobiliary junctions. There is a scenario, clinical scenario, in which a patient presents with an symptomatic cholelithiasis planned for laparoscopic cholecystectomy. Unfortunately, the intraop findings were not picked up by pre-op ultrasound. Surprisingly, intraoperatively, we find a nodular liver with extensive collaterals in HDL suggestive of liver cirrhosis. So the next management could include any of the following except close and evaluate cirrhosis, convert to open subtotal cholecystectomy, open GB, remove stones, and do a tube cholecystostomy. So everything was suggested in the recent Shackelford except for conversion to open, because conversion to open, particularly in a cirrhotic patient, the postoperative period is going to be stormy. There will be a subcostal incision, and he may have ascites. There can be postoperative pulmonary morbidity and so on. So if severe cirrhosis is incidentally found in intraop, there should be a low threshold to consider alternatives such as intraoperative cholecystectomy to averting surgery, depending upon the patient's status and severity of the symptoms. Subtotal cholecystectomy in this scenario, there are three types of subtotal cholecystectomy in which if the critical view of safety is not achieved, you just remove the gallbladder, remove the stone, need not go till the cystic duct junction with CBD. A small amount of infundibulum can be left, which can be used to close this. This is type A. Type B, in which the liver bed is so extensively involved by collaterals, but the critical view of safety is achieved. In this, what you can do is you can clip the cystic duct, come slightly above when you reach the liver bed, leave the posterior wall of the gallbladder there, and then remove the anterior wall and entire thing. Now, the type 3 is where both the posterior wall of gallbladder and the area of hilum is full of collaterals. In this, you can do both the things. Just leave the posterior wall of gallbladder there. Don't go till the cystic duct CBD junction, or don't go till the critical view of safety. Open, remove the stones, shorten the length of anterior wall of gallbladder as much as possible, and you can do a fenestrated type of cholecystectomy or subtotal cholecystectomy. Okay. So, which among the following is false regards to acute cholecystitis? Impaction of stone in the neck of gallbladder. Cystic artery infarction is seen 60% of culture positive in asymptomatic cases. Tokyo guidelines recommend perioperative use of antibiotics in acute cholecystitis. See, many may have bacteremia when they develop choledocholithiasis or acute cholecystitis, whereas asymptomatic cases, they are not positive. The bile is not infected. The very mechanism of acute cholecystitis, calculous cholecystitis, is caused by the impaction of stone in the cystic duct or the infundibulum, causing the GB to swell, and it swells. There is edema, there is a block in the venous drainage. Still, edema happens. The cystic artery goes in for infarct, and this ends up having a gangrenous cholecystitis and gallbladder perforation. Tokyo guidelines in acute cholecystitis, yes, they recommend perioperative use of antibiotics. Moving on to the next question, least common complication of portal hypertension in children, and the options include encephalopathy, ascites, varices, and malnutrition. Unlike adults, the encephalopathy component is very, very rare in pulmonary hypertension of children. This is because portal hypertension, the amount of children having non-cirrhotic portal hypertension are very high when compared to that of adults. Say 100 children in their first decade have portal hypertension. In India, 50 of them may not have cirrhosis. Whereas in adults, say above 30 years, 100 patients have portal hypertension. 90 or more than 90 patients will have uh, cirrhosis as cause for portal hypertension. So in adults, whenever the patients have cirrhosis, encephalopathy is very common. Whereas in children, encephalopathy is extremely rare because cirrhosis is not the underlying cause for portal hypertension. Unlike adults, malnutrition or failure to thrive, failure to gain weight despite good amount of eating. So all these can lead to malnutrition in children having portal hypertension. So the next question is child Tarkot score is 8. 2 HCC lesions are there, each 2.2 centimeter. What would be the next appropriate step? So the question is framed according to BCLC, and the options include put into transplant and do a bridging RFA, TASE with sorafenib, microwave ablation with sorafenib, and resection. Now, if we go to the answers may differ. Earlier BCLC, definitely these are not, they fall under intermediate stage B because CTP is between 7 to 10. CTP 8 means child Tarkot B. Okay. And they are multinodular. Performance status we actually don't know. So they are well-defined nodules. In earlier BCLC guidelines, they would have directly gone for TASE and then sorafenib. Whereas recent guidelines, there is a slight change. They can be either downstaged by TASE or they can be bridged. They need not be downstaged because none of the lesion is more than 3 centimeters, and there are no more than 3 lesions. So definitely they are well within the criteria of liver transplantation. Only thing is, till the waiting period, they can be put under RFA or any local therapy. So that change we need to see. Earlier, only early stage or very early stage were recommended liver transplantation. This time, intermediate and advanced stage with the preserved uh, performance status are definitely recommended liver transplantation too. Child record POC score components are all except bilirubin, INR, ascites, and creatinine. Obviously, creatinine is not included in child record POC score. We all know that CTP score is age-old score started to uh, claim the development of encephalopathy in patients undergoing shunt surgery. They included 2 subjective and 3 objective criteria. 2 subjective criteria include encephalopathy and ascites. Objective criteria included bilirubin, albumin, and PTINR. Each were given points. Note, there is no 0 in this. 3 points, 1, 2, and 3. So the least point will be 5 and the maximum point will be 15. Child A included only those cirrhotic patients having 5 to 6 points. And child C had somewhere between 10 to 15 points. So in between is child B. Now, MELD 3.0, the new parameter which was added is which among the following: sex of the patient, sodium, creatinine, and bilirubin. So the answer here is the sex of the patient. Creatinine was there from the beginning. Sodium and bilirubin were added in the previous versions of model of end-stage liver disease. Now, the model of end-stage liver disease was first quoted in 2002, and that was particularly to improvise or to find the patients who are at most requirement of liver transplantation and those who will be benefited by undergoing liver transplantation. So initially they had 3 criteria: INR, bilirubin, and creatinine. In 2016, 14 years after the first MELD, it became MELD sodium, where sodium was included in addition to INR, bilirubin, and creatinine. Now they have included albumin and 6. So creatinine, that this was the problem why MELD score had to be changed and why sex is involved as a inclusion criteria in MELD 3.0. Female had less muscle mass than men, so they produce lower amount of creatinine, and even though the advanced disease female tend to have low MELD. So that was given an additional point. And albumin, definitely they used to give us better idea of the current liver synthetic function. That is why albumin was also included in these criteria. So MELD 3.0 would give females 1.33 additional MELD points, which should help mitigate the gender-based disparity in organ allocation and should reduce the waitlist mortality for females. Okay. So regarding ICG, all among the following are false except it's accurate even in jaundiced patients. In other means, the ICG means of evaluating the liver function, which among the following is true. Okay, so they are accurate in jaundice patients too. It depends upon the blood flow uptake of a hepatocytes and excreted by the biliary radicals. It's a cationic dye and it's measured at 15 minutes after injection. So it's an anionic dye. It's injected and it's measured with a light emitting diode. 15 minutes because it's of its half-life. And the ICG, indocyanine green, is taken up by the hepatocytes through blood vessels and it's excreted without any change. Okay, so partially it is excreted by the biliary system, partially it is excreted in other means too. So the most appropriate thing here is it is measured 15 minutes after injection. They are not accurate in jaundice patients because if they are blocked, then definitely it is not going to get excreted in the biliary system. So this may give false higher values of retention of ICG in the blood at 15 minutes. So in order to evaluate the synthetic function of the liver before subjecting the patient for a major hepatectomy, so there are multiple tests available. Many dynamic tests are available and many static tests are also available. The dynamic tests half-life clearance include ICG, which is gold standard these days, being used extensively all over the world. Caffeine and bromosulfonane are also being used. Elimination tests like galactose and metabolic formation, like we used to radio-labeled carbon along with a substance which goes through the liver and gets metabolized, so that the radio-labeled carbon is set free from that substance. For example, aminoprin along with radiolabeled carbon, methacetin along with radiolabeled carbon. Now, if this goes into the liver, aminoprin and methacetin gets metabolized so that the radiolabeled carbon is let free, and that is excreted as CO2 through the lungs, and that can be easily measured from one's exhalation. The other thing is lidocaine or megex was used. This is depends upon the metabolic function of the liver. And these days, again, which are upcoming, include molecular nuclear imaging techniques, 99M technetium galactosylol, mebrofenin scintigraphies. Static tests, they do not, I mean, they are losing its significance because it may change from person to person. It may change depending upon the disease of the patient, and they are not going to exactly give us an idea about a synthetic function of the remnant liver. University of California, San Francisco, or UCSF criteria, all among the following is true, except options include two tumors of size 6.5 and 3.5 centimeter are well within the criteria of UCSF for liver transplantation. Three tumors, each 4.5 centimeter or less. Cumulative of three tumors should be less than 8 centimeters, and there should not be any extrahepatic spread. Last three are criteria for UCSF. First one, actually, the answer for the first one is C. See, the cumulative maximum three tumors can be present for them to fall within UCSF criteria. And the largest tumor size should not be more than 4.5 centimeter if it is multiple. If it is single, the largest size should not be more than 6.5. So if it is cumulative, even though the largest size is 4.5, the cumulative size should not be more than 8 centimeters, which means one tumor can be 4.5 and two tumors together should not cross 3.5. So 4.5, 2.5 and 1, or 4, 2 and 2. So Millen's criteria, solitary tumor maximum diameter of 5, add 1.5, solitary tumor of maximum diameter 6.5 is UCSF criteria. And multinodular up to 3 tumor nodules, each of which are less than 3 centimeters, add 1.5, up to 3 nodules, largest being less than 4.5. They have also included a cumulative tumor diameter of less than 8 centimeters. In both, there should not be any vascular or extrahepatic metastasis. So, introp image of a shunt surgery, which is shown here. What shunt is this? This essentially looks like some end of a vein is joined to the side of a vein. And they have given that this is a splenic vein. This they have not mentioned. So the end of splenic vein is anastomosed with the end of one vein. So that is proximal splenorenal shunt, in which a spleen is removed and the splenic vein is turned down and anastomosed to the side of left renal vein. So photosystemic shunts, selective shunts include Warren shunt and Inaguchi shunt. Non-selective shunts include Linton or proximal splenorenal shunt, egg fistula, which is not being used these days, and TIPS. Egg fistula is directly anastomosing portal vein into the IVC. Linton shunt or proximal splenorenal shunt with splenectomy is regularly followed. Warren shunt or distal splenorenal shunt, which was extensively being used or extensively being recommended in alcoholic cirrhotic patients for selective devascularization of the gastrosplenic junction, lost its significance because they used to form collateral at some other pathways, and the very meaning of preserving the spleen and eliminating the various gastroesophageal junctions failed. So there was one question regarding post-hepatectomy liver failure. which was not very clear. So I just made up some of the choices. So the question said that the hepatectomy will last for 180 minutes and 900 ml was the intraoperative blood loss. What is true about the post-operative liver failure in this patient? Expert clinical examination by HPB surgeon is most important to identify or classify or diagnose a post-operative liver failure. This patient already had two risk factors for post-operative liver failure. It is the leading cause of mortality, and post-operative liver failure is based on 50-50 criteria. The true answer here is yes, it is the leading cause of mortality. C is the correct answer. Uh, Obviously, the expert clinical examination by HPV surgeon is the least important one because these are objective measures and that is not based on 50-50 criteria. It is based on the criteria that uh, a post-operatively acquired deterioration in liver to maintain its synthetic excretory or detoxifying function characterized by increased INR and hyperbilirubinemia or after post-operative day 5. So grade A, it is a biochemical post-operative liver failure. Clinically, the patient is fine. Grade B is a deviation from regular clinical management, but manageable without invasive treatment like ICU requirement, dialysis, all those requirements are not there. And grade C is deviation from regular clinical management requiring invasive treatment. This can range from reintubation, resurgery, and mortality also. So it is always easy to remember grade A and grade C, and anything falls in between these two will be grade B. So these are few risk factors which can be patient related, which can be surgery related, and which can be post operative related. Patient related includes diabetes, obesity, chemotherapy associated steatohepatitis, viral causes for cirrhosis, preoperative malnutrition, preoperative biliary obstruction, renal failure, severe thrombocytopenia, preoperative lung disease, and age greater than 65 years. Surgery related, the estimated blood loss of more than 1,200 in the patients which we discussed was 900 ml. Intraoperative transfusion and need for vascular resection, greater than 50% of liver volume was dissected or only 25% of liver volume is remaining. Right lobectomy and skeletonization of hepatoduodenal ligament. Intraabdominal infection, post-operative hemorrhage. So one thing which is not included in this is more than 4 hours operative time for major hepatectomy is also included as a potential risk factor for development of post-operative liver failure in the patients undergoing hepatectomy. Now, post-hepatectomy liver failure is the leading cause of mortality in the patient undergoing a liver resection. The most common morbidity of a patient undergoing liver resection is by leak, and most common morbidity of a patient undergoing liver resection in a cirrhotic liver is ascites. Okay. So this question was there, which was not clear. I don't know whether this will come under general surgery criteria or criteria of between hepatobiliary. Lab coli, whether it is considered as a clean case or clean contaminated case, it will be essentially considered as a clean contaminated case only. So that is all for today's discussion of the recall session. And think I should go to, I'll open the YouTube and check for any questions there. So any doubts I can. So sorry, where will be the questions? Okay. While we wait for questions, I would just like to reiterate that for INI different question papers for each super specialty like gastrosurgery. We only have to read SG for SG and surgical onco for surgical onco, unlike SNEET SS. SNEET SS, everything is for everyone, but INI SS, it is only surgical gastro for surgical gastro. So the other sessions will be covered by Dr. Raj Mahendran sir and Dr. Arun sir in a day or two. So that's the first question, how to differentiate between type 1 and type 4 in MRCP. See, type 1, I just go to the slide where, see, type 1, it's a uniform dilatation starting from coming from distal to proximal, from the abnormal pancreatobiliary duct junction till the hilum, or sometimes main right and main left duct. There will be a uniform dilatation without any stricture. Whereas in type 4A, see, there is a stricture definitely at the level of hilum. It is not an uniform dilatation. And again, if you see here, there is a dilatation of main right duct, main left duct, and after that it is narrowed down. I'm checking for any other doubts if present. Okay, first order biliary radicals are extrahepatic or intrahepatic. Now the answer is there are pelihilar cholangiocarcinomas. Initially, hilar cholangiocarcinoma was the term used. Now the standard term used is perihilar cholangiocarcinomas. Now the perihilum means it starts from the junction of cystic duct with CHD. So the CHD essentially comes under the perihilar cholangiocarcinomas. Proximally, it goes till where the right duct splits into right anterior and right posterior, and left duct gives segment 4 duct and goes for common 213 duct. So beyond this is only second order. The first order is right main duct and left main duct. So perihilar cholangiocarcinoma starts from the junction of cystic duct with CBD. CHD is completely a perihilar region. Hilum is a perihilar region. Right duct till it splits into right anterior and posterior is a perihilar region. Left duct till it splits into segment 4 and common 2 and 3 duct is a perihilar region. Topics to revise in last 10 days for INI SS Surgical Gastro. I think you just follow our DocTutorials modules. Please follow the recall sessions. Please follow the exams. I think definitely that should do. And 1 day before examination, you go through all numericals or numbers. For example, some incidences, the mortality rate following a major resection, incidence. What is the percentage of type 1 choledochocyst? More than 70%. All those numbers, no, it will be difficult to retain for a long term. So just 1 day before, that is enough. So if no more questions, then I think I can call off today's session. Thank you for patient listening. And we have other sessions for esophagus, colorectum, bariatric, pancreas to be covered by Dr. Raj Mahendran sir tomorrow. Thank you.
Thank you, sir.
Okay, I'm signing off.
Bye,
Okay.
sir. Good night.
Bye-bye.